Welcome to ETSU Department of Psychiatry's Grand Rounds. Dr. Barton Evans is going to be talking to us today. Dr. Evans got his Bachelor's of Science at Tufts University in Medford, Massachusetts in psychology. He got his Ph.D. in clinical psychology at the American University in Washington, D.C. He did his postdoctoral fellow in clinical psychology at Yale University School of Medicine. Postdoctoral education consists of an advanced psychotherapy training program, Washington School of Psychiatry, 3-year program in psychodynamic psychotherapy, program in management development at Bryan School of Business and Economics, University of North Carolina, advanced clinical training program, National Center for PTSD, Clinical Laboratory and Education Division in Palo Alto, California. Also completed 3-level training in therapeutic assessment with Stephen E. Finn, Ph.D. Center for Therapeutic Assessment in Austin, Texas. Dr. Evans has worked in a number of different facilities, community health centers. He's worked in Manassas, Virginia, for the Prince William County Mental Health Center, worked at the Karma House, Rockville, Maryland, Counseling Center at Georgetown University in Washington, D.C. as the assistant director. Also worked at Counseling and Testing Center at University of North Carolina, Greensboro, North Carolina, and American University as well, visiting assistant professor. He's been a clinical and forensic psychologist at the Department of Veteran Affairs in Montana, Bozeman, Montana VA Medical Center, and the Charles George VA Medical Center here in Asheville, North Carolina. He is currently a professor in our Department of Psychiatry Behavioral Services, the Associate Director of our Outpatient Services, and Director of Psychological and Forensic Assessment Services. Dr. Evans has written numerous books and papers on personality assessment, Rorschach testing, and has attended numerous different conferences throughout his CV. So, Dr. Evans.
In the back row particularly. Can you hear okay? Okay. If I start, my voice sometimes fades. If it does, just make a motion. And so what I'd like to do today is to talk to you about one of my passions. This is actually my first official faculty member grand rounds. I've been here twice before. I did one about 2 years ago on PTSD. Last year I did one on personality disorders. And now today I'm going to talk about what can personality assessment do for you. Here's a disclaimer that I guess the only conflict is that I have several books and another one coming out pretty soon. And I'm not going to be talking about my books. Okay. I also want to appreciate Dr. Irving Weiner. I don't know if for those of you in psychology know Irv Weiner. He's been an important person, mentor for me. And he is letting me borrow liberally from a workshop he did on this subject. So the goals for this presentation are to talk about the utility of personality assessment and differential diagnosis and case conceptualization. I'll go back. The role of personality assessment and treatment planning, outcome evaluation as a therapeutic assessment intervention in and of itself. The complementary values of test batteries that include both self-report and performance-based measures. Those are the old objective and projective tests, and I'll talk to you why we're not using those particular terms these days, as they're not particularly descriptive. And if we have time, I have a forensic case that was actually a national case that got me very involved in teaching in the Rorschach. We'll see how our time goes today. So let's jump into it. Okay, what is personality? Okay, a lot of our training today in psychology is around behavior and cognition, but we tend not to think about where behavior and cognition fit into the overall picture of the personality. The concept of personality is this composite of what we are like as people, how we're likely to think, feel, and act. And it's a defining characteristic of personality resides in an individual's both states and traits. That becomes important when we're thinking about assessment. Let's see. Okay, a personality state is the current content of a person's thoughts and feelings comprising relatively transient affects and attitudes that arise in situational circumstances, such as being happy or being deeply in thought at the moment, okay? So we all have different states, depending on the kind of interpersonal situations we find ourselves in that may take us away from the things that we commonly are like. There are sometimes we, or maybe a calm person but get upset because of situational events. Personality traits are, in fact, our abiding dispositions to behave in a recurrent way across certain kind of situations and comprising of fairly stable characteristics. And I think if we just think about what we know about each other, if we sat down and said, well, what kind of person is Barton Evans? And you could say, well, he is this way, that way, and the other way. And it was the common state. You might find that he's tired some days, but generally alert others. An example of this is to be a shy, reclusive person or a persistently enthusiastic or outgoing person. We'd think about that as introversion or extroversion. And Harry Stack Sullivan, who was one of my heroes, talks about personality as a relatively enduring pattern of interpersonal situations which characterize a human life. So he takes a look not simply at personality as residing in the person, but personality residing between people as well. So what is a psychological test? We use the word psychological tests all the time, but what is a test? And basically, it's a systematic procedure for obtaining samples of behavior relevant to cognitive, affective, and interpersonal functioning, and for scoring and evaluating these samples according to standards. There's objectivity due to the standardized stimuli and procedure, and there's also objectivity due to standardized norms and research. And by standardized stimuli and procedure is that when we give a test, we give the test the same way each time. And so what we have is a standard way of presenting test material around which people will respond according to their own individual personality characteristics. The objectivity in terms of norms and research means that we know that when a person we know what the average person, how the average person behaves on a particular test, and if somebody is outside of that, we know that that's a characteristic where that person is, in fact, significantly different than the average person. So one way of thinking about that is we give a Beck depression inventory, and generally people score below 8. If we start getting scores above 8, we know that people are starting to deviate from the average way in which people might present in terms of depression. And then as it goes up, we begin to become more and more confident that this person has a depressive feature, or as it gets higher, a depressive disorder, or as it gets even higher, somebody who is really profoundly depressed and may need very, very immediate intervention. That's a very nice way of helping clinicians, as we're going to talk about later, kind of figure out where their client is at a particular time. And we'll talk about why that's important above and beyond interview. Because that's, of course, what we do a lot of these days is interview somebody and talk about both the pros and the cons of what interviews can do for us. Psychological assessment, on the other hand, is a flexible, non-standardized process that integrates multiple sources of information, including psychological tests, for the purpose of arriving at opinion about psychological questions or issues. Personality assessment is a core type of psychological assessment that uses empirically supported measures of personality traits and styles to help refine clinical diagnosis, structure treatment, and increase the accuracy of behavioral prediction. Of course, that's what we're trying to do here, is to become more able to say, if we get a person who presents in this particular way, they're likely to continue, and say in the case of the Beck Depression Inventory, they're likely to continue to be depressed for a long period of time with all of the negative consequences in their life. And neuropsychological testing, developmental testing, and cognitive assessment are all relevant to personality assessment. Collaborative and therapeutic assessment is a model in which psychological testing is used to help people understand themselves better. And it differs from traditional assessment, whose main goal is to diagnose disorders, plan treatments, and evaluate effectiveness of interventions. TA, therapeutic assessment, serves all of these purposes, but with the primary goal of facilitating positive change. And this is a particular model that takes the power of psychological testing and allows us to intervene around the kinds of concerns and questions that people have. Either a referring physician or therapist, or a way of starting therapy oneself. This is probably one of the two most important areas of development in personality assessment, and I think it's something that we're starting to see very good research to support the efficacy of. Okay. So psychological testing is a standardized procedure. They lend themselves to being quantified. In many ways, psychological testing is the original evidence-based technique because its tests are developed around evidence. And psychological tests are often more efficiently revealing than clinical interviews. The research on clinical interviews in forensic setting and other settings indicates the ability to make diagnosis and standardized predictions are not quite as strong as we might want to think. For instance, the research on the capacity to tell if somebody is lying or malingering. Generally speaking, clinicians simply on interview are no better able to tell whether somebody is lying or malingering just from interview itself than the average person, which has an important, of course, important implications if you're using it in court. When you start adding other information like collateral information and background information, you increase the capacity to predict better. And then if you add psychological testing, specialized psychological testing, you really increase when you have all three of those together. Psychological test findings are more fully validated than impressions from clinical interviews. So testing is a very powerful tool and something that I think can be incorporated in standard clinical practice and psychiatric practice without a lot of extra effort. I mean, you can do certain things that will really help you a lot. And then, of course, you can get into the more complex kinds of problems, which we'll discuss a little bit later. Okay. So we want to, when we think about testing, usually the way that I get a testing referral is that somebody contacts me and says, I need psychological testing on this person. Anybody see any problems with that? What's that? Why? Yeah, I mean, you can test a person all sorts of different ways, but you don't know what the question is and then how do you develop an underlying approach that allows you to interpret the testing? So testing is testing for what in answering what kind of question. And the more specific one can be, actually the more successful the testing and the more satisfied the referring clinician is with the outcome, because we can then begin to hone it down. This talks, by the way, is kind of argues against the idea of a standardized battery, because standardized batteries are kind of like shotgun approaches as opposed to getting very clear questions and then beginning to refine your testing and use those instruments that will best answer the kinds of questions that are being posed. It helps organize reports around key considerations. It helps explain the basis of conclusions, because of the test scores, what they signify in terms of the dimension of personality rather than the test scores themselves. Test scores only give us an opportunity to say that this person is more likely to some degree or another like this than they are like that. Test scores in and of themselves are useless. And it helps us determine what personality assessment is relevant and has anything to contribute. Because sometimes the desire for personality testing wants to go at questions that really cannot be answered. Okay. So what kind of conditions call for treatment? I'm going to move into psychological testing and its value in treatment. We have psychological, pathological disorders, which I call the disorders formerly known as Axis 1. I don't know how many of you feel a certain loss in the Axis 1, Axis 2 way of thinking. Yeah, totally, yeah. You trained with Ted Milan, you would. So, and then we have the chronic and maladaptive patterns, again, the disorders formerly known as Axis 2. And then we have persistent adjustment difficulties, including adaptation to medical issues, which is going to become more and more important as we begin to move, as I think we are, medically towards integrative care. I mean, that's actually a presidential debate topic about programs and Hillary Clinton and really pushing the idea of integrative care so that mental health care is embedded and psychiatric care is embedded in medical care. I can see advantages to that, and I can also see some disadvantages to it. But anyway, I think that's where we're moving. Certainly Medicaid and Medicare is definitely moving in that direction. Okay. Now, when is there a need for diagnostic clarification? Okay, if somebody comes in, says they're depressed, you do an interview, a good interview, looks like they have a simple, mild to moderate depression, you're able to talk to them in a way that you kind of get to the basis of it, you prescribe good medication or something for anxiety disorder, and over the course of a month they get better. This is not symptom complexity. Now, how many, I'm not going to ask for a raising of hands, but how many times do you get a psychological referral that has that level of complexity? I don't, well, and maybe because of who I am, but I never get it. It's almost never the case that that there's low symptom complexity. And I think there's reasons for that. The other issue is that if we really look at particularly Axis 1 and the DSM, there's a lot of symptom overlap. I just did a presentation at American Psychological Association on the kinds of symptoms in PTSD and the areas of overlap with other disorders and also with normal functioning. Okay, so, symptom of PTSD is startle response, right? So if somebody has a startle response, they have PTSD. Well, increased startle response is found in almost every, when we look at the research, found in many, many psychiatric disorders, and it also turns out to be one of the common things that we have inherited. If you come up behind a child and make a loud noise, you do not have to teach a child to startle. That's inbuilt in our system. So just that right there, I've got startle response. Well, you don't know what you have. You know that you have person startle. Is it outside the norm? If it's outside the norm, what are the conditions? It doesn't really tell us. Concentration problems are found in a variety of psychiatric disorders. So it becomes very important sometimes to be able to sort out symptom overlap. And psychological testing psychological assessment is a particularly good way of systematically sorting out the complexity so that you can target your intervention around the complex of symptoms that are actually presenting. This I call resolving multiple diagnoses. And this is, how many times have you gone into a chart and you found 4 different diagnoses, 5 different diagnoses, 12 different diagnoses over the course of 20 years, depending on the therapist? So which one's correct? Well, usually a diagnosis is given at the time as a helpful way of trying to focus treatment. But when you see a lot of different diagnoses over time, then we have what I'm going to call the blind man and elephant problem. And I'll talk about that a little bit more. And then, of course, sometimes when somebody is coming in with a medical problem, if we don't get a clear sense of what the underlying psychological issues are, then medical treatment itself can be undone, very fine medical treatment, because of the personality issues. And again, all of these are valuable for diagnostic clarification. Okay. Symptom complexity, the seeming and actual presence of multiple diagnoses and the impact of each on the overall functioning. Psychological testing allows us to tease that out. I'm going to give you a quick example of a 28-year-old man who reports with subjective distress, difficult. Whoops. Did that go out? No, there it is. Difficulty getting out of bed, episodes of confusion, memory problems, social avoidance, relationship difficulties, career indecision, and an inability to work. That's what he presents on interview. What's the diagnosis? I mean, can we carve a diagnosis out of that? Can we also carve another one? Can we also carve a third or a fourth or a fifth? So what are these diagnoses? Let me go back. So what? Just kind of shout out. What's this person's diagnosis? What's that? Depression. Any others? He's volunteering into treatment. Good question. Context. So if somebody is presenting and we're having a lot of symptoms, would be helpful to their legal situation. You might have even another issue to deal with. But let's just keep it into clinical practice. So this is a person who's depressed. Any other diagnoses? Absolutely. Substance abuse disorder, possibility. Not reporting with it, but one thinks about it. Anything else? Could be schizophrenia, right. Thought confusion, what's that? Could have a general medical problem. Anxiety. ADHD, personality disorder. So, bipolar variant. So, perfect, okay. He has been, over time, diagnosed with dysthymia, major depressive disorder, ADHD, and bipolar disorder. He never had a diagnosis of a personality disorder, okay? He was treated, when I saw him, with 2 depressive medications, a mood stabilizer, and 2 stimulants medications, none of which seemed to help. Nothing of which seemed to help. These are the symptoms of this guy on medication. and very medicated. Psychological testing revealed that this guy had severe major depressive disorder, far worse than he was reporting, and at a level that was shocking to both him and to his therapist. But it was very clear from his testing that his level of depression, as reported, and across a variety of instruments, both self-report and performance-based, both objective and projective, that the level of depression on this, for this guy, was extremely severe. And at times to the degree that his thought loosened. Not enough to get the psychotic additive diagnosis, but so severe sometimes that he would become profoundly confused. He also met standards for ADD without hyperactivity. And he had when we looked at the records, he had a long history of learning problems in schools that seemed to be related, even though this guy was extremely bright. This guy coded for avoidant personality disorder, onto which all of this stuff was overlaid. And then when we look down even further, that all of this was fueled by profound shame and self-attack. This guy had severe, he was so ashamed of his inability to get out of bed, his inability to function, that the shame itself became an important treatment thing because he thought, I'm depressed. A lot of people get up out of bed and go depressed, and what's wrong with me? I must be a lazy guy, which was, as you can imagine, the family didn't disagree with because this guy living at home. So in terms of intervention, the recommendation was for aggressive psychiatric treatment to really deal with the severe major depressive disorder symptoms, to back off this cocktail of medication and really work on finding a medication that would drop the depression. A review and change of his ADD medications that would act in concert with the depressive medications. Important family intervention, letting them know that this guy really did have a severe depression, more severe than anybody had noticed, and that he wasn't just being lazy or being stubborn, although he was. But not lazy, but he was a pretty stubborn guy. And the psychotherapy intervention, which really, I think, was the thing that kind of potentiated all of the others, was to address the profound shame and self-attack, which, along with the clearing, when some of the major depression started to clear, gradually reduced, and his concentration got better on both sides from both the AD medications. And of course, concentration difficulties are found in depression and very much in major depression. Along with the clearing, gradually reduced some of the long-standing symptoms of the avoidant personality disorder. So here's the outcome. His level of energy increased. He became more physically active and got out and started doing things physically, again, which has an antidepressant effect. He volunteered. Rather than jump into a job, try to find something where he could volunteer in an area of his interest, and he was able to do that, and very soon was able to be seen as a valuable person, as a very, very bright guy. He then applied and was accepted to a prestigious graduate program in a different city. He was able to leave the family. In graduate school, he did so well. He got he got invited to be admitted to doctoral study with a full teaching assistantship, and he's now teaching college-level courses in his area of interest. He now has a group of friends and is dating. Now, this is, of course, I'm picking an example of a case that worked really, really well, but it's not uncommon when a therapist is stuck and a psychiatrist is stuck, and they're really working and they have difficulty kind of sorting things out so that we could see more clearly, and then we could then take a look at the interventions at the variety of different levels that then allowed the therapy to get going because all of the elements could be addressed. Okay. As I said before, many DSM disorders have significant symptom overlap. It gives the impression of comorbidity when it may or may not be comorbid. And it creates what I call the blind man and elephant dilemma. I don't know if people are familiar with the Sufi tale of the blind man and the elephant. And careful psychological assessment can clarify diagnostic dilemma and focus treatment better. And so this is a profound representation of that ancient Sufi tale. You know, an elephant comes into a city of blind men, and they each grab a different part and say that that's what an elephant was. I like particularly the one towards the left. That is the reason I selected this particular one. But this is not uncommon where you have a limited amount of time with a patient and you're trying to do the best you can within the focus of that limited. And sometimes that works really well, maybe most of the time, but some of the times it doesn't work, and sometimes stepping back and getting a much broader perspective on the person using evidence-based methods of psychological testing and assessment can actually open up the therapy and treatment, and psychiatric treatment as well. Okay, and so there are just times when you get a case and all of a sudden what you realize is that people are seeing this person in a whole bunch of different ways. And so how do you as a clinician resolve this variety of different diagnoses, some of which kind of fit together, some of which don't? And I'm going to argue that psychological testing can help you when you get a client that has had a variety of diagnoses to help you kind of integrate that and to focus your treatment in a more evidence-based way. And then, again, this is a topic that, that Carl and I are beginning to have an important conversation about, if you don't mind my saying, in no small part because he did a lot of research and training with Theodore Milan, who was the developer of some of the most important, actually the most important behavioral health measures. So, and so we have tools like the Milan Behavioral Health Inventory and the Milan Behavioral Medical Diagnostic Scale that will help somebody in a medical problem to begin to take a look at not only the psychiatric issues, but the stylistic issues and how those stylistic issues interact with treatment of certain disorders. You know, for instance, in cancer, where depression, you know, depression is important, but if a person is a passive, resistant, pessimistic person, they're at a higher risk with the same disorder than somebody that's active and more optimistic and more directive in their life with the same level of neoplasm invasion. And so those, you know, you really want to begin to take a look at those particular issues in the care of that person, because simply giving the person chemo may be necessary but not sufficient. Okay. I'm going to skip over some of this. Why do people become involved and benefit in treatment? And anybody that wants, well, I think this is on the ETSU website, but if anybody wants a copy of the slides, I can do that. I'm just going to kind of roll through these given the time. Let you take a quick peek, because I'd like to present a case, and I would like to present something about As you can see, there are different elements here in psychotherapy, and you can kind of break it down into categories that allow you to begin to think more systematically, generally, about how to take an approach. And then personality assessment can help get a clearer picture so that you can focus your psychotherapy. If you're doing insights-oriented psychotherapy with a person who has limited insight, you're probably going to be hitting your head against the wall unless you make major, significant sort of treatment modifications in your standard method. So testing can help you assign priorities to treatment targets. Like in the example I gave, the main issue that the therapist started with, besides getting him a new look, psychiatrically, was really to focus on the avoidant personality, but even more than that, to take a look at the shame and self-attack. It really helped the therapy focus in on that, and that issue got worked through. Things kind of snowballed in the other direction. And actually some of the avoidant personality characteristics began to fall away because his long-standing shame from early childhood made it less necessary to take an avoidant approach. Now, when we're looking at obstacles to treatment process, we're not saying these people are not treatable. What we're saying is that these have to be taken into account when we start to think about the length of time, the kind of vulnerability to premature termination, and working actively on discouragement and hope in the treatment setting. So when we're thinking of starting any kind of treatment, we're really interested in knowing the level of disturbance, anywhere from neurotic to borderline to psychotic. We want to know about dangerousness to self and others. Is there an imminent decompensation? And is there a faulty support system? These are all very, very critical in starting off treatment of any sort. And these are pretty much profound grasp of the obvious here. Okay, I don't know if you know the old song. I think it was Ella Fitzgerald and Louis Armstrong song. I say tomato and you say tomato. And it goes, let's call the whole thing off. So anyway, so this is, I'm using this to talk about this new reconceptualization of psychological testing. How many people use how many people know about the difference between objective and projective testing? Okay? So, what's objective about an MMPI? Is that an objective observation of behavior from an outside point of view? Or is this a person's view of themselves, which may or may not be objective? To some degrees it is, some degrees it isn't. I'll talk about why not. So, and also projective tests, a lot of the data from projective tests, particularly the Rorschach, are not particularly projective. And in fact, on the Rorschach, there are only certain parts of the Rorschach that's scoreable that really get at projection. When you see card 5, which is the bat card, or butterfly, or bird, it's really important for you to see that because it objectively looks like that. There's no projection there. If it's an attack butterfly, now we got some projection. If we have the Joker smile, maybe we have some projection. If it's flying, we have some projection. But a lot of the Rorschach is really around the degree to which a person can perceive objectively. So what we've done is we've began to shift the standard and using, instead of objective testing, we're using self-report because that's what the nature of the report process is, and then performance-based tests, methods in which we're getting samples of behavior and coding those samples of behavior. It's actually a behavioral coding type method. The focus is on the response process, and the self-report methods are like the MMPI, the MCMI, the PAI, performance-based methods, or the Rorschach, the TAT. Anybody ever heard of the adult attachment projective? It's awesome, 7-card project. That is a projective test, really. So the response process of self-report methods is introspection, retrospection, and self-attribution. Performance-based is stimulus-based attribution with attention directed outward. Stimulus is on the task, not on the self, to which the client provides meaning and structure, and it may be influenced, or likely is, by less self-conscious processes. For instance, psychosis is much more reliably picked up on the Rorschach than on the MMPI. In fact, it's Rorschach's single best test for, if you could pick one out of the group, for assessing psychosis. Because what you're getting is measures of poor reality testing and funny thought interpretation or thought disorder. And it really is a superb method in that way. The advantages of self-report methods is that they're easy to learn, easy to score, not as much face-to-face administrative time. You sit somebody down in a room. It's limited by a person's self-awareness and by their response style. Self-awareness is the degree to which a person is accurately able to introspect about their behavior and to represent it on the test. And response style means the degree to which a person wants to let you know about their problems. If somebody doesn't want to let you know much about their problems, then that's going to influence the kind of, quote, objective results that you get. Fortunately, some good tests like the MCMI, MMPI, and PAI, and a variety of others have response style scales, which are actually among the best things on those tests. But we are limited on these by our awareness of ourselves and also by the degree to which we want to reveal ourselves. And sometimes we reveal ourselves in a more disturbed way than we are, because there's certain advantages to that. Performance-based tests are much less limited by self-awareness. It's less limited by response style. It's pretty hard to fake a Rorschach. And it's limited by the difficulty in learning the administration and scoring. It's a very complex instrument to learn. I would say that it took me about 7 years of very, very intense study to become adequate at it. I think I probably was adequate earlier than that, but my level of adequacy. And it probably took me 25 years to learn to kind of run it around the block at a high speed, to kind of use it as a kind of a Maserati. And there's significant client and assessor face time in administration. So there's a bias in terms of time and the quickness with which we're supposed to be doing our work these days to the self-report methods, but they have significant limitations. Self-report inventories are likely to be particularly sensitive to personality traits. When we look at the MMPI, which is the sort of 900-pound gorilla of, quote, objective testing, the test-retest reliability for 3 months is only high on one scale, relatively high on one scale. And that's the scale 4, psychopathic deviancy. It looks like it taps something there that's a little more reliable. But, you know, you have a test-retest below an adequate level 6 months, you're really not getting its psychological state. trait as much as you're getting a psychological state. Performance-based measures are really more sensitive to personality traits. The test-retest reliability on a lot of the measures of the Rorschach, 6 months, a year, and 3 years later, is actually quite impressive if we look at the research on that. If self-report is easier and more efficient, why not just use it? Well, you get incremental validity for the same criteria variable by using different methods. Self-reported symptoms of psychosis versus directly observing reality testing and thought disorder. Monomethod approaches using self-report have low predictive validity if we look at the test. And it's having a multi-method approach is, I would argue, not only valuable but essential in forensic contexts. And there's a really great article on the bottom if you're interested in that. Okay, this is get a little fancy, but we're going to skip through this because of time. So why aren't we using projective/performance-based tests more? In the 90s and continuing for about a decade or more, a small group of clinical psychologists published a series of critiques of the Rorschach and other projective tests in both scientific journal and a book for the lay public. It called for the moratorium on the Rorschach based on their findings, and under the banner of science, it had a chilling effect on practitioners' use of the Rorschach and other methods. Some of the criticisms related to blatant misuse of the test that had not been adequately addressed in the assessment community. Other concerns involve some weakness in the research based on underlying performance-based tests, and then other issues involved a variety of biased criticism under the mantle of good science. This led to a particularly productive period of scholarship to respond to the critics. Some special issues in psychological assessment. The Society for Personality Assessment did a white paper on the status of the Rorschach in clinical and forensic assessment, and said that the science did support that. And then Giacono and Evans wrote a book called The Handbook of Forensic Rorschach Assessment, which tended in just, the criticism started to die down. This thing is a brick. This book is a huge book. In fact, if you have insomnia, I would suggest this book before I would use hypnotics, because it really, no, I think it's a fascinating book, but we really addressed the issues. We got the top experts in the Rorschach from around the country and the world to address, I think, 28 chapters of issues on the use of the Rorschach. And it's had a very good effect. It's kind of a pretty good achievement to be able to get a book that answers critics in a very valid, in a very important way. Okay, is the Rorschach psychometrically sound? The Exner's comprehensive system was an attempt to bring science, and it was a good attempt to bring science into a system that, is really vulnerable to garbage in, garbage out. You get a Rorschach, and then you interpret the Rorschach. What are you getting? Are you getting an objective measure, or are you getting this person's own projections on this other person's? Anyway, he developed a standard administration, with great reliability. He revised the comprehensive system 5 times based on new research, and he developed a set of norms and re-standardized those norms. And this is not getting norms of the MMPI where you sit a room of people down, hand them a bubble sheet, and have them take it. I mean, you sit down and you're administering Rorschachs to non-patients. And then the meta-analytic studies show meta-analytic validity results similar to the MMPI. I think 30.33.34, which is very consistent for personality variables in the field. And it's a significant addition to other things. In the last I'd say 8 to 10 years, the comprehensive system has been updated by something called the Rorschach Performance Assessment System, or the RPAS. And it uses a new administration that leads to more accurate inferences. It uses a different reference group from around the world, which was an incredible achievement. There was some tendency for Exner's norms on about a third of the variables to over-pathologize. The interpretations, the cut scores, were a little too low, and this has kind of corrected that. Administration and coding improvement with better benchmarks led to intercoder reliability, and most importantly, in 2013, Mihira, Meyer, and colleagues published a meta-analysis on the major 68 variables in the comprehensive system, where they went back and they took a look at all of the research on the Rorschach, on the variables of the comprehensive system. And what they did is they harvested the variables that have very high quality research, moderate, low, or no, or some variables that had no research whatsoever. And so their system is actually has harvested the best variables scientifically as part of their new system. But just so that you take a look at this in a broader sense, when I did this presentation, I just put Rorschach into Cyclet and see how many hits we got. And I got over 11,000 hits on the Rorschach in the scientific literature, almost 6,500 of which were in peer-reviewed journals, whereas the MMPI got close to 1,400 hits with 9,200 peer-reviewed articles. There's a substantial indication that the Rorschach is an active instrument in the scientific literature, and as a result meets standards for court. See how we're doing here. Okay, let me kind of run through. This was a pretty high-profile case, one that made the national papers and People magazine and things like that, so I can talk about it. This is a case of X versus Y, the value of comprehensive multimodal assessment in a custody dispute. The Rorschach was conducted blind in the context of an assessment of potential psychological problems in parents in a highly contentious custody evaluation. The rest of the evaluation was done by an experienced custody evaluator using clinical interviews, collateral material, review of data, and the MMPI. One parent had accused the other parent of sexually abusing their two children in common. And this is one parent is X, they're divorced, leading to multiple reports to Child Protective Services and full physical exams of the children. At about the fifth time that happened, DSS intervened to basically raise with the court the possibility of one parent misusing the Child Protective Services system, because there were no findings in any of these. So the basis of the opinion overall was interviews with parents, teachers, MMPI, Rorschach. I did the Rorschach blind and then integrated it with the other psychologist. And then they were independently evaluated by an expert from Hopkins in assessment of child sexual abuse. Was not a part of this evaluation. One of the parents showed real significant difficulties in relationship to the other parent. The MMPI was invalid due to pervasive denial of psychological problems. For those of you in the MMPI world, we're talking about an L scale of 84. It's a really hard thing to get an L score of 84. And you begin to say, okay, this person is not revealing problems. So the Rorschach was an important instrument here because it's a harder test to control. And it found significant problems in judgment in one parent, vulnerability to impulsive, poorly conceived behavior, interpersonal problems verging on borderline-like personality traits. Notice I'm not using a diagnostic term, but actually you're talking about traits. The finding of the independent evaluator was that that MMPI in one parent was unreliable, interpretable, and that the problems that I had a rebuttal expert who was, in fact, Howard Garb and James Wood, who had been the debunkers of the Rorschach. And I was petrified. And then afterwards, ashamed of myself for being petrified. And they reviewed the custody report, including the chart with the MMPI result. One of them interviewed the parent in a hotel room, and their testing was the borderline personality module of the SCID-2. Anybody just think about what the problem basing an opinion on that is. And a review of the Rorschach results scored and interpreted by an unnamed expert because the expert talking about the Rorschach, who in this case was Garb, didn't know how to administer it and didn't know how, had really given to in graduate school. So he got an unnamed person who decided that the Rorschach was bad and I did it wrong, which is sort of like saying the food is awful and the portions are too small. Anyway, so in the first outcome, the trial was delayed when the parent's attorney dramatically recused himself from the case. A rebuttal expert said that found no interpersonal difficulties and the person didn't have borderline personality disorder, which is not something anybody had said. Found the Rorschach to not be credible, and it was scored wrong anyway. The Rorschach was scored and interpreted, and but because he didn't have sufficient training. Parent, who was the problematic parent, was given limited supervised visitation, and the judge stated that the rebuttal expert's testimony was not helpful. So in the case itself, the Rorschach played a very important role in helping to take a look at the disturbance of this person. But we got to have something that's kind of unusual in forensic cases. We get to take a look at an outcome. This is outcome 2. A masked intruder entered into the home of the custodial parent at night and shot that parent. In the ensuing struggle, the parent pulled off a ski mask to reveal the college roommate and best friend of his ex-spouse, who was a government official who was later arrested and charged with attempted murder. She had, by the way, a satchel full of child pornography that she was planning to plant as part of this thing. The ex-spouse was also arrested and charged with attempted murders, and both parties were ultimately convicted on 20-year jail sentences for attempted murder. In terms of issues of predictive validity, did the Rorschach show, and we think of the outcome, did it show problems in judgment, impulsive, and poorly conceived behavior? I think so. When you try to murder your ex-spouse as a way of dealing with the problem, I would call that impulsive, poor judgment, impulsive, and poorly conceived behavior. Interpersonal problems, verging on borderline-like personality traits. Okay, thank you very much. I think we're pretty much at time, but I'm happy to stay if people have any questions, or we can take questions now, and if people need to run off, you've got folks in the schedule to take. Why don't you go ahead and... Any questions? Yes? Right. Absolutely. So the question was, we understand that these things can be helpful, but the real world question is, can we get it paid for? And the answer is yes. And there's a particular procedure by which you go. You have to get it pre-approved, but if there is a significant documentation, like this is a complicated case with treatment failures, they will give psychological testing. I've been able to get up to 16 hours approved by insurance, Medicaid and Medicare and Blue Cross Blue Shield. You know, if they go in that direction, I just talk to them, okay? And you know, people need education, and that's a really good opportunity to educate people about the science. And so it's just a matter of people having particular ways of doing things, and we know that there is some tendency towards barriers to care in insurance, and so we just overcome them by having documented conversations with people. And I haven't had trouble, actually. I haven't had a rejection. Yes, Tom?
So I'd like to make a broader comment about how I think this whole issue of testing affects not only things that are directly related to testing, but also affects the research base for other things, including psychopharmacological research. If you go back to 1960s and 70s, at a time in history when it was rather common for somebody entering a psychiatric hospital to get a full battery of tests.
Full battery, yep.
The data available from that period in time gives a very different picture of treatment outcomes as compared to what we get now. So for example, in pharmacological research now, what we measure are self-reports of symptoms. We don't have performance measures for the most part on those things.
No.
If you go back to the 1960s and 70s, you can find research reports showing that intensive psychotherapy raises IQ. There's a series of studies out of Menninger, another series involving children. One study showed a series of cases in which average increase in IQ as a result of intensive psychotherapy was 27 points, not shabby. But we don't measure those things anymore. If you give somebody 12 sessions of CBT, you're not going to see that. And so our whole sense of how the clinical world works is in part shaped by what we choose to measure routinely and the kind of data we get.
Right.
And I think that's an important thing.
You're singing my song.
Right.
You know,
Okay.
okay, you know, both in terms of the psychodynamic and the value of psychological testing and that sort of thing, and integrating it
Right.
in comprehensive
So we
patient
now
care.
operate under this fiction that intelligence is this fixed, immutable thing and that our treatment isn't going to affect it. But in fact, we've stopped measuring it, so we don't know what our treatment is doing. A second thing, I'm just going to offer it as an alternative way to think about the use of these instruments in forensics. My view is that when you use something like the Rorschach in forensics, you're introducing an inferential step in the process that can be hard to bridge in a courtroom. So for example, in the case you used where you have a Rorschach result suggesting impairments in judgment and some impulsivity and so forth, well, that's nice, but it's much more effective in court if you can actually show those things behaviorally.
Absolutely. You wouldn't take a Rorschach to court that didn't have
Right.
powerful corroboration.
So I think what's important is that there be that the Rorschach is simply an element of a bigger picture. It's a cross-validation piece as opposed to proof. Now, in the other case you cited, the criminal case, at least in Tennessee, that evidence would not even be admissible in court.
And it wasn't used in that.
Okay, and the reason it wouldn't be admissible is that the legal standard doesn't conform to the test data. The test data is saying to you, this person has some impairment. Tennessee courts have said, we don't care about impairment in criminal cases. It's not admissible unless the testimony is that there is a total incapacity. So if you want to say, well, somebody's ability to premeditate was impaired, sorry, you don't get in the courthouse door. You have to say they were totally incapable of premeditating. And if you can't reach that level,
Right.
you're not even going to get to give your
so if they're
opinion.
totally incapable, how did they do it in the first place?
Right.
I mean, it's a kind of catch-22 standard. So, yeah, you know, we wouldn't ever use a single test in the data. I using that to as an inference, but it was a case where that was the data that really kind of gave us evidence-based empirical validation to some of the self-report, interview, and other things. Yeah, in criminal, absolutely. Yeah. Any other questions? Yeah.
Well, it's a shame that there's not more people here at this point. That would have been good to have more interaction around this. But one thing that I wanted to hear you comment on, Barton, was to what extent do you think it's important to recognize balance between persistent pattern of behavior indicative of personality per se and situationally driven behavior that is going to be more variable in specific kinds of traits, and how you look at that across different traits that relate to the judgment of the presence of a personality disorder?
Right, right. So the question is really basically the importance of differentiating state from trait. I think we all know that any one of us under certain situations can find ourselves vastly confused and outside of our normal behavior. You put the right set of circumstances, and you can take a very solid human being and subject them to life events that will then lead to sort of situational kind of difficulties. It becomes absolutely critical not to take the presenting problem as the person, but to actually go back and to see whether there are current stressors that are really modifying behavior. You know, for instance, somebody, let me just give an example. Somebody was sitting at a light, and all of a sudden he hears a screeching sound, and a giant car comes and rams him from the side, just going about 40 miles an hour. They're sitting at a traffic light. Sitting there, everybody's knocked out. He wakes up, and then all of a sudden, the car comes back and hits him again. Okay, that's a pretty powerful life event. And this guy had severe PTSD. But he was not a guy, he was a guy who was a very well-balanced, accomplished, easygoing guy. And so the assessment brought out that this guy's basic foundational trait was very, very solid, that allowed us to move very rapidly and very directly into the current symptoms. And he was able to resolve. He still had trouble the rest of his life with things that suddenly appearing from the right. But in general, he got back to his work and was functioning at the level, that he was before. Does that kind of respond to it?
Yeah, in part, because I don't think it's all captured by state versus trait.
What's that?
I don't think it's entirely captured by state versus trait.
Uh-huh. So what are your thoughts?
Well, so you can be looking at state versus trait in terms of just an objective characterization of
Right.
what the person is in a specific situation versus what they generally might be like. But that isn't the same as looking at to what extent persistent patterns of behavior that would refer to a personality disorder are maintained across multiple situations versus to what extent situational specificity impacts
Absolutely.
those
So
behaviors.
personality disorders having an element of creating repetitive conflicts, and then that would mean that particularly in personality disorders, we would want to take a look at the interpersonal behaviors and the degree to which those behaviors will, create a kind of crisis mode of living. And that if we only deal with the crisis, then we never get back to the underlying borderline personality. Is that what,
That's
Yeah,
what
yeah.
I'm targeting, right?
Again, singing my song. That's why I think psych testing is so powerful, because in the case that I saw with that I used of the young man who was so depressed, nobody had ever assessed axis 2. And ultimately, the key was this feeling of shame and self-attack that was so much the center of what he was doing. And as that went better, the medications worked better. I don't think he has that personality disorder now. which is interesting. You know, can personality disorders be cured or shifted? And I happen to believe they can. There's some pretty interesting research on borderline personality that with the right kind of care, people stop having it. So anyway, we have now just the chosen few, and I suspect people would like to head on back to their lives. All right. Well, thank you all for coming.